welcome, those of you here and those of you online. And it's my great pleasure to be able to introduce Paz, who I've got to know through some work we're doing around cardiovascular disease in pregnancy, which I know many of you are also interested in. So Paz, over to you.
Thank you. Thanks so much. And thank you, Deborah, for the invitation to speak to you all today. It's a real honour to come here. And I haven't been in Bristol since student days, so it's also just very nice to come back here. Right, I just need to find the slides. There we go. So yes, as Deborah said, my name is Paz. I'm a consultant cardiologist and I have a research group at the National Heart Lung Institute in Imperial, and that focuses on genetic cardiomyopathies. And I'm a clinical cardiologist specialising in inherited cardiac conditions at the Royal Brompton Hospital. So the main focus of my research group at the moment, funded by the MRC also, is on sex differences in cardiomyopathies, which are heart muscle diseases. I know we're probably from different backgrounds and disciplines, but my mother's a paediatrician, and so I remember growing up and just constantly hearing the mantra that a child is not a smaller, shrunken adult. And I feel like I'm going to spend the next chunk of my adult professional career saying that a female heart is not just a smaller, shrunken version of a male heart. So at birth, hearts are sort of similar size, and then the male heart will undergo a rapid period of growth in adolescence, and then that mismatch remains throughout adult life, with the male heart being larger. And there are lots of other macro and microstructural differences. But importantly, none of those differences are accounted for in clinical care. So for most heart conditions, the diagnosis and treatment is the same, agnostic to sex. And the reason that that potentially matters is that actually, to the women in this room, what do you think you're most likely to die of in life? Deborah, you're not allowed to answer. Yeah, Amy, you're reading the room. Most people who ask that question will say breast cancer, because that is the sort of popular messaging. But actually, globally, heart disease is the #1 killer for women, and will kill more women than the cancers combined. But the misconception that heart disease, cardiovascular disease, is a male disease means that the disease in women in particular is understudied, undertreated, underdiagnosed, underrecognised. So I sort of authored this British Cardiovascular Society document last year about how we can find ways to sort of advance the diagnosis and treatment in women to reduce that health inequality. And so that's why sex differences and certainly the cardiomyopathies are a research priority in my group. And the focus at the moment is to look at the risk factors for cardiomyopathy across a woman's life stages, the unique reproductive lifespan, look at whether we need sex-specific approaches to diagnosis and treatment of these diseases, and then get some understanding of the mechanisms that drive some of these sex-specific differences. So one example that I will talk about in the first part of our talk is a condition called dilated cardiomyopathy. So this affects about 1 in 250 people. It's where the heart gets bigger, baggier, and doesn't pump blood as effectively around the body. The current way that we diagnose it is sex neutral. So we use imaging cutoffs to make a diagnosis. And the popular wisdom is that it affects more males. And so we wanted to know and evaluate whether that was also true in genetic forms. So most rare forms of the condition, rare genetic forms of the condition are due to genes that are inherited sort of in a monogenic, classic Mendelian autosomal dominant fashion, where you would expect a balanced sex distribution, so a 50-50 distribution. So we set out to assess the sex ratio in dilated cardiomyopathy stratified by genetic status. And it really is the work of some really fantastic early career researchers who are listed on the slide. So they undertook a systematic review to look at the identifiable sex ratios in the published literature, and then did a meta-analysis and meta-regression to look at the pooled proportions in different subsets. So an overall dilated cardiomyopathy cohort, a purely genetic cohort, and then a certain genes, gene specific, and then a gene negative cohort. And then we took the study to the UK Biobank and looked at diagnoses that were being made and then applied sex-specific imaging and genetic diagnoses to see whether that would change the sex balance that we are seeing. So in the meta-analysis, overall there were 37,000 participants from 99 included studies. And whichever way we sliced and diced this, there were more males reported than females in these cohorts. So in the all-cause dilated cardiomyopathy cohort, the male to female ratio was just over 2 to 1. Similarly for the genetic cohort, and even if you break it down to the specific common genes, so titin and lamin cardiomyopathy, more males than females were still affected. And even in the gene negative cohort, still all more likely to be males than females. So putting it all together, there was a consistent male preponderance across all published cohorts of dilated cardiomyopathy. And this just sort of illustrates the forest plots for the monogenic DCM and the gene elusive DCM on the right. Please do.
So I'm assuming you took into account the overall number of males and females in those studies.
Yes.
You didn't just.
Yes, it's all proportion based.
Yeah. Okay.
Yeah, it's all proportions. And so this is the gene specific cohort. I think we're only really powered for titin and lamin here. And so those are the results that I would lean towards. But even then, there's a male preponderance where we wouldn't expect it, because these are all genes that are inherited in that sort of autosomal dominant Mendelian fashion. So there's potential reasons that could underpin this. So either males are more vulnerable to getting the condition for some reason, or conversely, females are in some ways protected. Theoretically, you could argue for maybe a higher female mortality with the condition before diagnosis. I think that's quite a stretch, but it's plausible. And then I think another option which formed the basis of our next investigation was that females were being underdiagnosed. So they were having the condition, but just not being detected in the community. Crucially, these numbers don't tell us if it's a diagnosis issue or if it's a penetrance issue, and we'll come back to that later. And penetrance is that sort of genetic concept whereby if you have a genetic variant that could cause disease, how likely is it to manifest disease? Because not all genes are completely penetrant, certainly for the cardiomyopathies. So if it's a diagnosis issue, if we go back to that first part of that puzzle, are we missing disease in female patients? So there are a number of reasons that we might miss disease in female patients. One of those is incorrect symptom recognition. So as part of a lot of public patient engagement, I did, as part of this research program, I've sort of lost track of the number of women who've told me that their symptoms were misattributed to something else, and they took the long and winding roads to getting their diagnosis. Menopause was a common one. The average age of onset of DCM is between 40 and 50. The median age of menopause in the UK is 51. It's actually World Menopause Day coming up later, I think this month or next month, and we're doing a big education piece around, what are real heart symptoms and to not ignore those in female patients. So symptom misclassification of symptoms is one option. The other is incorrect diagnostic thresholds, and this was then the next chunk of focus in our group. So if we take the example to myocardial infarctions, that's probably one of the few areas of cardiology where we do have sex-specific diagnostic cutoffs. So this is myocardial infarctions diagnosed based on troponin thresholds in the presence of symptoms. And when we know that the troponin normal ranges differ by age and sex, and so some really great work by the Edinburgh team, Nick Mills, Dave Newby, and those guys up there, showed that applying sex-specific thresholds, which are now used in practice, can identify 5 times as many women with myocardial infarctions. So really good application of sex-specific diagnosis. Unfortunately, the diagnosis doesn't lead yet to improved outcomes. So even though we're better now at diagnosing women, we're not better at treating them. They're not getting the prognostic care. But that's, I guess, a difference between biology and bias. That is a conversation topic for after the talk. If we go back to how we diagnose dilated cardiomyopathy, it's based on dilatation and impairment of cardiac function, which is based on the left ventricular ejection fraction. This is just a little snapshot of the British and the American and the various societies of echo or cardiology. None of them can agree on what normal is. So there's a persistent challenge of defining what is normal, and this is all sex agnostic. But I think it's important. This is a large echo study from Australia showing sex-specific cardiovascular related mortality at equivalent left ventricular ejection fractions. So for those in the room, these plots here show that at equivalent left ventricular ejection fraction, so the same number, women experience more cardiovascular mortality risk than men at an equivalent ejection fraction, but that is not at all accounted for in clinical practice. So we view a number of 30, 35, 40 as the same in males and females. The absolute sort of change is small, but the relative difference is higher. And so why is this important? So this is our work published last year, showing that women with dilated cardiomyopathy had what looked like a better picture. So they had less big hearts, less dilated, they had better function, less scarring, less like lower biomarker levels like the troponin. And so things looked good, so they should be doing better. But actually what we see, that particularly in the early years of their diagnosis, the women are in red here, they had a twofold increased risk of heart failure events, so admissions to hospital with advanced heart failure symptoms. So how come they are doing worse if everything looks on paper like they should be doing better? And I think this probably goes back to the sort of premise of that left ventricular ejection fraction, that way that we're saying that they look better is actually different for males and females. And so this is very old data from the Dallas Heart Study in the 70s. And even back then we knew that women had, this is healthy people, like in the community, that women in the dotted lines just had higher left ventricular ejection fractions than males, than men. And so the theory is now that I think if a woman has got impaired left ventricular ejection fraction, so a reduction, to get to the same level of reduction, a woman's had to do worse than a man. So if her left ventricular ejection fraction is higher than a man's, it's still relatively worse for her than a man.
How come women have a better ejection fraction whilst normal than men? What does that?
It's probably to do with the size of, yeah, exactly. And we don't scale this because ejection fraction is a proportional measurement of blood. So it's not indexed in the way that dilatation. Exactly. Exactly. So to test this out, we then went to UK Biobank in the 47 or so thousand people who had had genetic sequencing and cardiac MRI scanning. So we were able to sort of do genotype first approaches and imaging approaches to diagnosis. So first we just looked and to see who had an ICD, so who had an existing community diagnosis of dilated cardiomyopathy, and those being diagnosed were overwhelmingly male. So the male to female ratio was 4.5 to 1. So higher than we saw in those, even higher than we saw in those published cohorts. We then applied sex-specific criteria, which we developed based on normal ranges, sex-stratified normal ranges, and 2 standard deviations above that, in the way that current diagnosis is applied in a sex-neutral way. And that reduced, but didn't fully eliminate this imbalance. So we went from a ratio of 4.5 to 1 male to female to 1.7 males to 1 female in an imaging first approach. And then when we looked at those with genetic abnormalities and the imaging criteria, it was very similar. It was 2.3 to 1. So still male. So a decreased male to female ratio, so a more balanced cohort when using sex stratified diagnostic criteria. So if we now put together those 2 lines of evidence, so we have the published research, the meta regression showing a male preponderance, and then we have the UK Biobank study showing male preponderance that reduces slightly. These suggest the evidence of sex-specific penetrance and underdiagnosis. So it's not a simple answer. Yes, women are being underdiagnosed, and if we applied sex-specific diagnostic criteria, we would probably diagnose more women with DCM. But even if we did that, it looks like we would probably still see more males being affected, because for whatever reason, there is a sex-specific bias and penetrance for this disease. So both things can be true, and in science, it's not a nice, neat answer. There are obviously caveats to this story in that we weren't able to analyse every particular gene that affects individuals in DCM. And over the course of this study, the DCM clinical diagnostic criteria did change. But we did various sensitivity analyses, and the overall conclusions are robust to that. So I've told you now that there are sex differences in DCM prevalence. What's driving those? And these are sort of the explanations that we could come up with, but I'd be always delighted to hear more and other options. So one option is that there are underlying differences in the genetic architecture, so the causes, the genes that cause dilated cardiomyopathy. The other is that these differences are just differences in the stages of disease onset. So actually, all we're picking up is that males might present at an earlier stage in their disease, and that if we wait long enough and go looking hard enough, females might present at a different stage of disease. Other option is, as we mentioned, there is a difference in genetic penetrance for some of these genes. And then finally, are there environmental factors? So we are working our way through this list, and I will share some of the findings from these approaches. So if we want to think about that first option, so is the male preponderance in DCM due to sex differences in the genetic architecture of DCM? So we think about 20 genes are causative for dilated cardiomyopathy. And if we offer genetic testing to a patient in front of us with dilated cardiomyopathy, about 1 in 3 will have a positive genetic yield, we think. 1 in 5, 1 in 3, sort of depends on who we're testing. So we then took this cohort across the UK in this BHF-funded Go DCM study, 900 patients with dilated cardiomyopathy, and compared the frequency of rare genetic variants in the genes that we know to cause DCM in males and females. And overall, for most of the genes, actually, the genetic architecture was the same. So it doesn't look like it's the genetic architecture that's underpinning it, except for one very interesting gene called desmoplakin. So that's a gene that affects the desmosome, so the cell-to-cell junctions. And for reasons that currently remain a mystery, this is a threefold increased odds of being affected in females compared to males. So it completely bucks the trend for all the other genes and all the other arrhythmogenic genes, so the genes that cause arrhythmogenic cardiomyopathy as well. So I've got a BHF-funded project, a PhD student starting next week, who I think we're going to try and get to why this is. And so then we did population penetrance estimates using sort of cross-sectional approaches in unaffected cohorts, and we're able to show that not only is the frequency higher in the disease cohorts, but at a population level as well, the penetrance of this gene is higher in females than males. And conversely, the penetrance of titin, which is the commonest genetic abnormality, is higher in males than females. So I think that's an interesting part of the puzzle, but clearly this desmoplakin gene only affects less than 5% of people with dilated cardiomyopathy. So and titin affects sort of 10 to 15%. These aren't driving sort of the headline big ticket differences that we're seeing, but I think show the importance of actually taking these sex stratified approaches. And the reason that this sort of work is important is because females who have desmoplakin have more arrhythmias, so they do worse. So we now show that they're more likely to get the disease and then have more complications. So that identifies a higher risk female subgroup with dilated cardiomyopathy. So the second of my 4 options was that are there differences in age of dilated cardiomyopathy onset? So this is a large, some published data at the moment of 3,500 patients worldwide from an international consortium that I co-lead called DCM Share. And there are basically looking at the top plots, there are no sex differences in the age of diagnosis between males and females. So this suggests that neither males or females are presenting later or being diagnosed later than the others. Look, across the board, whether they're gene positive, gene negative, or unknown, there's no differences in the age of diagnosis. So it's probably not a disease stage issue. If we go back to penetrance, the bottom Kaplan-Meier is a cumulative disease incidence by age for both genotype positive on the left and genotype negative or elusive on the right. And it shows that potentially in the gene positive, so the left-hand side ones, have earlier disease onset in gene positive males. And this is likely driven by earlier penetrance, as we saw on the last slide, in Titan males. So again, small but subtle differences, unlikely to account for the overall majority. And so the final thing that we sort of come to is environmental influences. And so this is work that we published earlier this year, looking at that unique female reproductive elements of that unique female reproductive lifespan from menarche to menopause and everything in between. And at the moment in the cardiology clinic, you don't ask about that. And we know that pregnancy and its complications are a period of accelerated cardiovascular risk, cardiometabolic risk, but then these women are sort of left. And so this was work using CPRD, so the UK Primary Care database. We showed that women with hypertensive disorders of pregnancy, so they affect about 5 to 10% of pregnancies, were associated with a 2-fold increased risk of developing dilated cardiomyopathy. And the women who developed dilated cardiomyopathy with a history of hypertensive disorders developed it on average 5 years earlier. So the median interval is 10 years for unaffected women post-pregnancy, and the women who were affected developed it 5 years earlier. And it looks like increasing maternal age at the time of first pregnancy and the development of postpartum hypertension are the strongest sort of mediators and risk factors. So this sort of adds to that growing body of evidence. We know that hypertensive disorders of pregnancy are associated with coronary disease and coronary risk factors long term. We now, with evidence like this, know that it also portends heart failure risk. And so it may support long-term surveillance of women, but I think we probably just need to target who and how, because resources. So yes, I've left a lot of time for questions, but in summary, the opening was, does sex matter in dilated cardiomyopathy? And I would say yes. So in terms of diagnosis, we have a higher male prevalence, and we have underdiagnosis in women, and we have sex-specific penetrance. All these things can be true at the same time. I would argue that we should consider the application of sex-specific diagnostic criteria for dilated cardiomyopathy. And I think in the future there is work to be done immediately and near term to explore the genetic and environmental factors that are underpinning that disease risk disparity. I pinged my imperial email up there, so please, whoever you are in the room or online, if you think there's areas of opportunity to collaborate, synergy, then I'd be delighted to hear from you. Thank you very much.
Thank you. I need to get a bit tech savvy, and I'm not, and see if I can see anybody online wanting to ask questions. But we can start in the room. Anybody in the room? Yeah.
Yeah, I'm just wondering if I want to about someone.
Yes, so that is being done currently. And it looks like testosterone has a modifying effect in females, but not in males, and that it's linked with myocardial fibrosis, which is the amount of scar in the heart. And we know that fibrosis links to outcomes. So it looks like there's a potential modifier in females only, and that may just be that the levels and the ranges are different, whereas for males there's constant higher exposure.
Really great tool, thank you. I'm a rheumatologist, so very out of my comfort zone. But when you showed that data about the age of diagnosis is similar, is that using your sex stratified or sex specific diagnostic criteria, or is that using the old diagnostic criteria?
Old diagnostic criteria.
So do you think that's part of it? That if you had these, can you apply your newer diagnostic criteria to that data and then see if those ages shift?
Yes, I could do, but what I wouldn't have is I would, in that particular cohort, because it's a consortium of established disease, what I wouldn't have is the earlier spectrum. Whereas with UK Biobank, I've got population level equivalent data. So I have affecteds and unaffecteds. In that, I would probably only be able to stage disease rather than make de novo diagnoses.
And with your UK Biobank data, going back to the relationship with the complications of childbirth, can you? I'm sure UK Biobank has data on how many pregnancies women have had. Can you look at women who haven't had any pregnancies and then use that as a sort of a poor proxy of these sort of maternal health problems? If that makes sense. I don't know if we do that.
Yeah, tell me more.
Well, being pregnant and I don't know, having postpartum hypertension or gestational diabetes, all those things, you need to be pregnant to have those consequences. So if you looked at women who've never been pregnant, is that a way of teasing out, just on a macro scale, on an observational way, whether these things are important? And then you can obviously link in genetics with that and understand if it's going into the pregnancy, whether you have some sort of gene pregnancy interaction that then triggers it. Just the thought.
Interesting. So with the CPRD data, the control that we'd used was normotensive pregnancies, but you're saying actually you need a third arm of just never being pregnant. Yeah.
You all know a lot more about this.
Yeah, that is problematic because women who don't have children, it can be by choice and it can be because they can't. And they tend to have worse, the latter tend to have worse cardiometabolic health stuff, PCOS, endo, like all of that is, so they are already a group and you don't know why they haven't had kids, usually in the big registers, whether it's because they couldn't or because they didn't want them. So it's a funny comparison than no kids to with kids. You have to be really careful and think about what you're getting out of that. Yeah.
Just related to this area, it's interesting we're all focusing, well, I suppose not surprising, focusing on the pregnancy. I wondered whether you'd looked at whether there's, outside of pregnancy and in general, there's a sex difference in the association of hypertension or blood pressure on a continuous scale with cardiomyopathy.
Yes, don't get me started on this. So it all adds to the lack of sex stratified diagnoses. We know that there are normal blood pressure differences between the sexes, and we don't apply those in practice. So are we missing hypertension?
Yeah, so if you look at that with cardiomyopathy, you may see a difference, which is driven by the difference in the sex distribution of blood pressure or of cardiomyopathy, or you may say no difference, and it's because one or both of those are cancelling out. It'd still be worth sort of thinking of, because we have, I think we'd be really interested in collaborating. We've got lots of different repeat measures of the original ALSPAC mothers and now their offspring who are in their 30s. And lots of people who are skilled at looking at trajectories and sort of,
But also we're getting on a subgroup through, Paul Leeson.
Yes.
So Paul's MRC program grant. So he's getting our ALSPAC mums to be phenotyped for HFpEF in preeclamptic or hypertensive disorders of pregnancy versus normotensive, with the idea of looking at a lot of the stuff that, but specifically HFpEF.
And at a stage of follow-up, So at a defined time point.
Yes, so now, so we're talking they're in their 60s.
The
Some maybe
median
early
age of the
70s.
mothers is me, and the median age of the dads is George.
Yeah,
Yeah, so early 60s.
yeah.
Yeah, interesting. Yes. That will probably get to some of the screening questions, which is what is the yield and what do we do about it?
Interestingly, there are tons of incidental findings. I've never seen such a high rate, which I guess makes a lot of sense because they're
Doing heart screening.
60s and spread around that. So there are a lot of referrals from for our mums that go to Paul. What we don't have, I mean, we have blood pressure measured at 18 years postpartum.
Mhm.
That's where Deborah got grants to bring the mums back in. So we can look at that as a potential, you know, but not kind of postpartum blood pressures because we don't have those. So we've got within pregnancy serial measures and then for 18 years on. Nothing.
So I think one really interesting unanswered question is what is it that's mediating genuinely that risk and when does it develop and what's the sort of time course of that? And we don't know that yet. I think Paul's probably the closest to figuring that out.
Mhm. Just want to check. Anybody who's there online, you've got questions, you can just shout out.
Look at there's that chat.
Ah, Emma. Emma, do you just want to ask your question or make your comment?
Yeah, I can. Hello.
Okay.
Lovely
Can
presentation.
you
Really
turn your
interesting.
mic up a bit, Emma?
Yeah, I can try. Oh God.
Oh, it might be us.
Is that any better?
It's okay, yeah, if you shout and I'll translate if anybody else can't.
Okay. Yeah, really nice presentation. I just wondered whether any of the increased male risk of DCM that you show is caused by other factors or behaviours, so like alcohol and drug use or other types of medications, like types of cancer medications, for example, or do you control for that in your analyses?
No, great question. So genuine alcohol cardiomyopathy, you have to drink 80 grams a day of alcohol for 5 years. So that's very sporting to get to that. But there's lots of alcohol use that is less than that, which certainly increases your risk of developing dilated cardiomyopathy. And in work that I published a few years ago, there's an interaction between alcohol consumption and titin genetic abnormality. So if you've got moderate, so not excess, but moderate alcohol consumption and a titin genetic variant, you're more likely to have a reduced ejection fraction, so reduced cardiac function than you would expect from either alone. So there's a strong interaction there. And so we know that general alcohol consumption is higher in males, and particularly in the age groups affected with or at risk for dilated cardiomyopathy. So yes, that probably does play a role. Cancer actually works the other way because one of the commonest sort of cardiotoxic chemotherapy agents, so the anthracyclines, are commonly used for breast cancer. So actually it's women who have that sort of long tail of potential cancer therapy induced cardiomyopathy. And then drugs, yes, again, overall likely to have a very small effect. So it will be higher in males, but most likely not underpinning what we're seeing.
Yeah. Okay. Yeah. Thanks.
Can I just going back to the what looks like a penetrance difference for these Mendelian genes, and this is going to show my ignorance of genes. What kind of, I mean, would that be evolutionary, or you know, what kind of things would drive something like that?
Yeah, not sure, and that is a real mystery. So is that penetrance influenced by external factors that only affect one or other sex? So an alcohol type equivalent that is almost like a constant environmental, or, and this is the subject of a lot of active research, other genetic modifiers. So not in the rare space, but sort of in that in between or common, the cumulative burden of common effects.
Yeah, alcohol would be odd because it's not like most people don't start drinking alcohol until later in life, so that it could affect the gene penetrance, which, if I'm right, you saw also outside of the condition differences. Is that
Yes.
right? Or yeah.
There's a couple of comments that might be useful to you, might not, around screening. So we did a similar kind of thing looking at asking screening for coronary heart disease. And our conclusion was, and we published this was based on data from the Norwegian Hunt cohort, is that whilst they are at so women with pregnancy complications are at increased risk of cardiovascular disease, actually when you do their we ask, do they cross the threshold for treatment earlier, and is it worth bringing them in for screening based on their obstetric history? And the answer was no. So there isn't a huge difference in their, it's no risk. That's the Norwegian equivalent of RQ risk. But that's a very different scenario than if a woman's already sitting in your GP surgery or in your whatever. Do you ask her, has she had preeclampsia or do you know what I mean? So
100%
there was absolutely no utility to targeting women with a complicated obstetric history and bring them in for screening. But that doesn't mean that you shouldn't ask, like our guidelines now say, you should ask about history of preeclampsia of women when you're screening them for coronary heart disease.
It didn't improve the
Nothing.
The risk.
Oh, the risk.
If it didn't add to what is already in Q risk or the prospective national one, and we've done that in loads of cohorts. So it doesn't shift the sensitivity or
doesn't at all,
specificity
because
at all.
it's not capturing anything new. Once you know the smoke,
Well,
the
exactly.
diabetes,
It's
the SLE or whatever,
kind
you're just not adding enough to the pregnancy complications. I think,
I think I completely agree, and I think there's a big piece of work to be done around just like women's education. So at the point of leaving, yes, but then just lifelong know your numbers.
Yeah, we always say it's the women kind of going to the women. I often think, well, it's not the women, it's the doctors who should know this first. And not many do, take it into a primary care, not a specialist cardiologist who does this every day. But like I spoke with just last week with a GP who was interested in women's health. She had no idea. Yeah.
Just going back to the sort of like that postnatal care, we've got a really good PhD student, and we're using the electronic health record data from different countries. And the idea is to try and do trajectories from a year before pregnancy, through pregnancy, repeated pregnancies, and see if that helps predict who and at what time should they be assessed. Because again, the CPRD work shows that I think it's less than 50% of the women who should have that 6-week check, either for gestational diabetes or preeclampsia or whatever. It's just not happening. And you can imagine lots of different reasons why. I can't remember now whether it was one of the meetings we're both in together or some of the meetings. There's certainly Diane Farah, who was in the group before, saying, the really tricky thing is we're brought up as midwives to not scare the women. So you don't sort of emphasize, hey, this is a lifelong condition here. You're kind of, because you don't want them to become worried about their baby. So they were sort of saying they really downplay this risk, which is understandable. But then after they've got the healthy baby in their arms is maybe the time to say, you do really need to go to that follow-up assessment.
Yeah, it's meant to be a 6-week mother and baby check, but it's mostly just the baby.
Great.
Chatting.
I was just going, when you started and we're talking about these sex differences, my PhD was collecting data and then using those data from the Women's Heart and Health Study. So I always feel I'm one of the last generation to do their PhD and actually go and collect their data in epidemiology, which is a bit of a shame, but there you go. Understandable. And it sounds great. Women, it's right up my field. Women's Heart and Health Study. But the irony is, it was the British Regional Heart Study, which had started 2 or 3 decades earlier, Jerry Shaker had got it funded from the MRC, and the idea was that was going to be one of the biggest cardiovascular cohorts ever. It had men and women in it. It was across the UK. We were going to centres in Northern Ireland and all the rest of it. And he showed me the letter from the MRC. Yes, we'll fund it, but only for the men. And then there were reviewer comments. And they were great because they were almost 50-50. Well, the women will just be the same as the men anyhow, and it just adds costs. And then the other half was saying, oh, these women are so complicated with their hormones and they'll just mess things up. And you kind of, I remember reading it and thinking, oh, like men don't have hormones, and the dichotomy, you just sort of think, surely somebody on the panel must have said, these two things cancel each other out, so let's include the women. And this was then, I'm pretty certain it was 2 or 3 decades later, when Jerry was no longer around, and Peter Wingcup and Shah Ibrahim got the, I don't know, the 10th or whatever follow-up of the men, and funding to bring in the women that would have been in had they, but and there are already a lot of them, and that was what I went and collected data on and what have you. But it's sort of that kind of assumption.
It's a big issue in clinical trials. So there's something called the participant prevalence ratio. So it's the ratio of the male to female ratio in the disease versus in your trial. For most cardiovascular treatments, that ratio is less than 1 for the trials. So they under-recruit women relative to the disease proportion. But I even think that doesn't make any sense to me. So let's say in DCM you have 70% males and 30% females. And so they would take that logical argument to be, so in a trial you should have 70% males, 30% females. But I actually think you should power it so that you can do sex stratified analyses rather than trying to replicate the disease prevalence. Because I think that's what you should ultimately be aiming at, to always be able to do stratified analyses.
There's, I mean, where some of that is still, although I think less, excluding women who may be of reproductive age or might be intending to have a baby or might be breastfeeding. But what's interesting from what I've looked at, and we're trying to look at it specifically in recent trials for COVID and the new obesity drugs, is that women either say yes or drop out sooner. And that's contrary to what happens in surveys and cohort studies where you have a preponderance, and nobody quite understands why. There's lots of theories that, one that goes around is they're more risk averse, and if you're going into a trial, you're being experimented on, whereas cohort studies and surveys, you're not. Others are just their lives. A woman sort of throughout her life course can be looking after children and then parents and so on. But it's sort of, there's, and what we're doing is looking at it from an epidemiological approach, but it sort of feels to me like it cries out for, within these trials, doing some qualitative research on that. But I haven't seen any yet. It's interesting.
Good.
Hey. Thank you very much.
Pleasure. Absolute pleasure. Thank you.
Yeah.